Professor and Head, World College of Medical Sciences, Jhajjar. And here we are to have an interactive session with Dr. Wani, who is Director of Bilmed Institute of Ultrasound. And he's here to discuss with us about uterine masses. Very doubtful and very important topic, and we have a lot of queries on this, and we'll discuss some common queries regarding this which are very important, and it's an eye-opener session. So doctors, let us start this session. Thank you.
So, greetings from Bilmed. We will discuss today a very vast topic, uterine masses. Now, in this uterine masses, we are having many things to discuss. You are already doing ultrasound, you are a trained gynecologist, you are professor and head of this department also. Now, let's discuss about these uterine masses. What type of masses we can have in the uterus? So, first of all, we'll be having some fibroids maybe. Now, these fibroids, location wise, these can be, subserosal.
Okay.
Now, when we are having subserosal fibroids, they will be distorting the uterine contours. So the point is, if you are not directly seeing a fibroid on the screen, but you are seeing a distorted contour of the uterus,
Okay.
maybe that you are having a very low-end machine,
Okay.
or maybe that you are not very trained to get these fibroids. What I am saying you, if you see a distorted contour of the uterus, most probably you are dealing with a fibroid. And which fibroid? Subserosal fibroid. So the point is, if you are having a distorted contour, you will search for a fibroid now.
Okay.
You will search for the fibroid, and you know why to search. Subserosally. Now, another type of fibroid, intramural. The intramural fibroids, as the term itself, intramural, they will be inside the walls. Now, another one, submucosal fibroid. Now, the submucosal fibroids, if there, will be compressing onto the endometrial cavity. Now, if you see, for example, there is a uterus over here on ultrasound, and you will be seeing a endometrium like this, but all of a sudden you see this endometrium having a bulge towards anterior or towards the posterior. Then what you are dealing with? Then you are dealing with a fibroid. If you are not seeing that fibroid, because this fibroid is compressing onto the endometrial cavity, making it to shift anteriorly or posteriorly. So, which type of fibroid is very dangerous? Submucosal. So, if I am having now another type of, if I am having a pendiculated submucosal fibroid, that is very much dangerous. Now, sometimes I am having a very big fibroid like this, a very big fibroid,
which is compressing the nearby structures also.
Right. Now, where this big fibroid will go? What I mean by that? This all, now try to understand, this all, your uterus, your both ovaries, bladder, where is the location? True pelvis or false pelvis?
So you are here to guide us through all that. So mostly it is in the false pelvis.
True pelvis. This all is in true pelvis.
Oh, this all will be in true pelvis.
Right.
This fundal.
Let us discuss first the true pelvis. Okay. This all is in
true pelvis.
True pelvis. So if you restrict your scan onto the uterus and the ovaries only,
okay,
what you will be missing is the false pelvis. But there is a fibroid or any mass in the false pelvis which will not pop up on the screen.
Okay.
So make a habit to scan the false pelvis also.
Okay.
Then only you will be getting to know that I am having there some pedunculated fibroid or any type of mass. So these are some masses which can be there in the uterus.
So these are some common masses.
Common masses, yeah. Now plus two, we can have endometriotic patch. Now we have to differentiate whether I am dealing with an endometriotic patch or a fibroid. So endometriosis also will be, there will be some patches in the myometrium, which will be some endometriotic patches. So these are some common uterine masses. Plus two, maybe in ovary I am having a cyst. Then we have to differentiate whether we are dealing with a simple cyst, complex cyst, a dermoid one. Then we have to differentiate a dermoid from an endometrium. So these are some masses which are commonly seen in the uterus. Now here we are not taking a course.
Okay.
We are, guiding you regarding what you have to, know about. Because if you are a gynecologist, you are having, I am sorry to say, not a very hold on ultrasound knowledge. You are having a knowledge of ultrasound, but you are a good gynecologist. Your topic is gynecology, but you are a bona fide sonologist also. It means that you can start your ultrasound career from day zero after completion of your post-graduation. But without knowledge, you will struggle all of your life. So now let us discuss one point only, one point. The best time to scan an endometrial polyp. Now you tell me.
Sorry to interrupt you, sir. So this is a very, very common confusion in our gynecology, and we are always calling the patient for scan at the what time we should call the patient and what see polyp. As you know, in OPD, in our infertility patients, in our menorrhagia patients, this is very important, and basic history, basic signs and symptoms which our patient gives us will helps us to diagnose the pathology inside the uterus. So sir will guide us and throw all the possible important points about the best time to see the endometrial polyp. So here we are, sir.
So first of all, remember this: as is the father, so will be the son.
Okay.
Now, what I mean, I will come to that, but remember this: as is the father, so will be the son. This is very important over here. This ultrasound needs a detailed theoretical knowledge. Then only you can hold up. Don't hold the pro without any knowledge of ultrasound. Otherwise, you will struggle whole of your life. Now, let's talk about this polyp. This polyp echogenicity. What is the echogenicity of this polyp as compared with the myometrium? Is it more or less?
I think it is same as myometrium.
No. As is the father, so will be the son. All answers are in this line. As is the father, so will be the son.
So it will be more.
Why it will be more?
Because it arises from endometrium.
Right. As is the father, so will be the son. Now, this endometrium arises from the endometrium.
Okay.
Endometrium is hyperechoic than myometrium. Am I right?
Yes, you are right.
So, as is the father, so will be the son. So, the polyps will be hyperechoic as compared to myometrium.
Okay.
Now, if I am having a hyperechoic thing over here, now see, hyperechoic thing over here, a polyp, and if my endometrium, I am in luteal phase, and my endometrium is very thick. Okay, if my endometrium is very thick, this is the endometrium over here. If this endometrium is very thick, not only thick, but hyperechoic also, because
Okay.
It is hyperechoic only, plus to thick. So let us make it hyperechoic. So this red will be the hyperechoic. But we know that the polyp is also hyperechoic. I will see a thick endometrium only.
Okay.
I will see a thick endometrium only if I am scanning a patient on day 20, 24, 25.
Okay. Okay.
So in a luteal phase endometrium, I will not be able to see a polyp. What I will see is the, a thick endometrium only. More thickened, I will say, more thickened because of the polyp.
Okay.
So if I am expecting a, 12 millimeters endometrium in a patient, for example, but all of a sudden I am not having a 12 millimeters, but I am having a 18 millimeters endometrium. I am not seeing a polyp because I am in luteal phase. But this 18 mm is itself a clue that I may be dealing with a polyp. This can be an endometrial hyperplasia.
Okay.
But if not an endometrial hyperplasia, then there can be a hidden polyp over here. Why am I using hidden? Because the echogenicity of this polyp inside the endometrium is equal, as the father told you the son.
So DD
will be a polyp over there. Now the basic question is, what is the best time to scan an endometrial polyp? Now you think yourself, is this luteal phase best?
No.
No. Now this is the polyp over here. Thinner, now try to understand, thinner the endometrium, more prominent the polyp will be, yes or no?
Yes.
Yes or no? So if I am at day 2nd, day 3rd, day 4th, I will expect a less thickness of the endometrium, and this polyp will stand.
Be prominent.
Yeah, then this polyp will say, hello doctor, I'm here.
Okay.
Now try to understand, if I will insert a saline over here, this is the endometrial cavity here. If I will insert a saline over here, will this polyp not say you double hello madam?
Yeah, because saline will create an
acoustic window. Now you cannot afford to insert a saline in each and every patient. Now if you are scanning during menses, you will expect some fluid in the endometrial cavity. So this is the natural sonosalpingography.
Okay.
You don't need to insert the saline. Insert the probe during period. So I am not recommending to insert this probe during the menses, but the basic important point is that if I am at day 2nd, day 3rd, day 4th, this polyp will be more prominent over there as compared in the luteal phase. So the best time to scan an endometrial polyp is now.
Day 2 or day 3 of.
And try it once to insert the probe during menses. It will be as equal you have inserted the saline. So in a DD case where you don't see any maybe there is a small polyp over there during menses, you will see a better picture.
This was a master stroke actually.
So now actually these are the common questions. Now see, these are the common questions which any gynecologist is facing daily. Now sonographic findings of a fibroid, whether I am having a fibroid or I am having something else, that something else can be maybe an adenomyotic patch, maybe a polyp also. I have to differentiate. For that, I should know the sonographic findings of a fibroid.
Exactly.
as is the Father, so will be the Son. Again applicable here.
Mhm.
Now, this is myometrium. This all is myometrium over here.
Okay.
This fibroid, if fibroid, mind my words, this fibroid, if it is true fibroid, will be having same echogenicity, almost same echogenicity with respect to this myometrium, yes or no? Think.
Yes.
Yes. Why?
Because it is intramural.
No, not this is intramural, because this fibroid is derivative of endometrium, yes or no? No.
No.
This is derivative of what?
Myometrium.
Myometrium, as is the Father, so will be the Son.
Okay.
So, the echogenicity of the fibroid will be almost equal to the myometrium.
Okay.
Now, if there is a polyp over there, the echogenicity of this polyp will be more than a fibroid, yes or no?
Yes.
Very good. Now, the first important point is that the echogenicity of
Depends
a
on
fibroid
location.
is not location.
Okay.
What it is.
What it is.
What it is. If it is fibroid, then it has to be equal to the myometrium echogenicity wise. And if it is polyp, it will be more than a myometrium, but it will be almost equal to endometrium.
Okay.
So, the sonographic findings of the fibroid. First, the echogenicity, which we have discussed now.
It can be hypoechoic also?
Yeah, it can be, but it depends on what it contains now.
Okay.
Now, if there are some red degenerations, which we will...
long-standing fibroid.
Yeah, long-standing. Now, if there are more of calcifications,
then it will be hyperechoic.
it will not be completely hyperechoic throughout. That patch only will be hyperechoic, but the base will be always equal to the myometrium. So this is the important point which you have to keep in mind. Now see the importance of the theory. Without training, please don't hold your probe. And if you are holding the probe, then you know that you are struggling each and every day. Now try to acknowledge that you are struggling, and you are acknowledging, not you, like a person
obviously,
who
but the mind doesn't know the eyes.
Yeah, right. What we are thinking and what most of doctors are thinking, I will go for a high-end machine. And after spending a half a crore, if not 1 crore, and if not crossing 1 crore rupee, those doctors are getting a machine, assuming that machine will do the job for me. At the end of the day, they will get a lot of buttons over there. More the money they will spend on the machine, more the knobs they will get. First of all, they don't know what wire is. I mean, the physics they are not confident with. Then this knobology will always struggle. They don't know what to press. They will press here, there. In fact, they are committing blunder over there. They are sitting in a cockpit.
Yes.
And if a pilot without a knowledge is pressing all the buttons in the cockpit, definitely he will crash land. And our doctor, whosoever is holding the probe without knowledge, is each and every doctor is crash landing each and every day. So go to any institute, have a basic training over there. Then you will see that a basic machine of 2 lakh rupees or 3 lakh rupees will do what a Voluson machine cannot do. Okay, coming back to the sonographic findings of a fibroid. Now, first of all, echogenicity. Echogenicity we have discussed, I will not repeat because this is not a class over here. What we are doing today is an interactive session. Yeah, interactive session of some important points. Now, second, calcifications. Will there be any calcifications? Yes or no?
Yeah.
If it is a fibroid.
There can be.
Yeah. So there can be calcifications. Now these calcifications are usually, I am using word usually, at the periphery. That is what we call eggshell calcifications. So calcifications will be there, yes. Now, if I am having a machine, I have spent more than even 10 lakh rupees, I will get a color box over there option. And our doctors don't know what to do with machine. Now there is a color option. Press on the color option, but before pressing on to the color option, don't think that machine will do job for you.
Hmm.
You have to get your job done by machine.
Hmm.
These are two different things. Now, when you are pressing onto a color, do all the color settings. Now, you will say me, what are the color settings? For that, there is a course over there.
Hmm.
Go through the book. Mr. Google is there. YouTube is there. So do a color Doppler of this fibroid, and you will see that I will be having some vessels again at periphery.
Hmm.
Why I am saying you all these things? Because I have to differentiate it with adenomyosis.
Okay.
If I don't know all this, I will never be able to differentiate it with adenomyosis. See, will you expect any calcification?
Hmm.
If it is adenomyosis,
Hmm.
think. Will there be any calcification if it is an adenomyotic patch?
No.
No. Why? Because this adenomyotic patch is a endometrium actually,
Huh.
ectopically implanted, which is connected hormonally. So this is a live tissue over there,
Hmm.
which is connected. This is important. Which is connected hormonally. So calcifications, if seen, is going in favor of fibroid, and if there is no calcifications, negative, that is going in favor of adenomyosis. Now, if I am seeing these color peripherally
Hmm.
going in favor of fibroid,
Yes.
but if I am seeing some central vessels also, what it is going in favor of? Think. Adenomyotic is a live patch.
So more of adenomyoma.
Right. So if I am having central flow, it is going in favor of adenomyosis. Come back. Okay. Now, if I am today scanning this fibroid today, and it is, like this patch, 40 millimeters.
Okay.
Try to understand. 40 millimeters, and I am having a report of this patient only, and the scan was done just 2 or 3 months before, and this 40 mm fibroid is there 20 or maybe at 25, maybe a 15 only. Will not you be surprised that how can a fibroid increase dramatically overnight?
Of course, I will be.
Is that actually fibroid what you are dealing with?
No.
No. That is actually the adenomyotic patch. Because adenomyotic patch
It's a
can
live
increase or decrease over a short period of time.
Live endometrium.
Because if there is more of pooling of blood over there, which we will discuss maybe in next point over there, which what is. So these are the sonographic findings.
Okay.
Then these mappings and all these things, these will be done, but condition to the basic stuff.
Actually.
Now, what is a mapping? What is a mapping? Mapping, this fibroid mapping is actually, when we are having a uterus in which we are having many fibroids. One here, another there, third one there, fourth one there, fifth one there. Tracing all these and making a sketch like, a map like. Now see, for example, you are having a GPS. What you are doing with the Google Maps, you are putting a location over there, then Google is giving you a track, a way, how you can land to that place from this. Now, I am having endometrium over here. Okay, for example, this is endometrium. I have to remove one fibroid. For example, I have to remove which fibroid I will remove, which is closest to the endometrium.
Okay.
How could I know?
Mapping.
Which is good. Mapping.
So it makes our management easy.
Management easy. And understanding of what is where, which fibroid is where. But the basic important point is that
How
you
to-
have to diagnose first one fibroid, then only you will do a color and all these mappings.
Okay.
Maybe you are doing a mapping over there, but actually these are not fibroids, these are adenomyotic patches over there.
Okay.
Try to understand. Adenomyotic patches all over, and you are thinking that you are doing a scan and you are having a fibroid over here, but actually these are adenomyotic patches.
So what is the best time you will prefer?
Wait. Because these adenomyotic patches are more single or multiple.
Single.
No, adenomyotic patches.
They are multiple.
Multiple. Now, if you are doing a mapping of multiple masses, thinking that these are fibroids, actually these are adenomyotic patches. Now, what is the question?
So what I want to know is what is the best time to differentiate adenomyotic patches from fibroid?
Now we will discuss that how to differentiate it from the. But
Best
the
time.
basic point is that sonographic findings of the fibroid get clear. Their sonographic findings of the fibroid first. Okay. Now UAG monitoring of the growth of the fibroid. Now first of all, now see, come back again. If I am having a clear-cut margins, if I know my borders of this fibroid, try to understand. If I know the borders of the fibroid, then only I can say whether it is decreasing or increasing.
Shrinking or increasing.
Getting the point? Now, I am having here, I told you just now, if I will be putting a color box over here, I will be seeing a peripheral flow, right? I will be seeing a peripheral flow, and if I see a peripheral flow, that peripheral flow will be over here, over here, over here, and over here. Point number one. Point number second, if there are some calcifications, these calcifications also, not in 100% of cases, but in most of cases, will be located peripherally.
Okay.
Like here. So why I'm saying this? These are the margins of the fibroid. These are the borders of the fibroid. If you are well versed of these borders, then only what you are measuring is the actual measurement of the fibroid. Then only you can say whether it is increasing or decreasing.
Baseline measurement.
Right. Baseline measurement has to be, pinpoint from the using the Doppler also, because Doppler also will guide me where from these vessels are, and where the vessels are, that area is the demarcation between the myometrium and the fibroid.
Okay.
And usually the calcifications are also located at the margins, at the contours of the fibroid. So this way we can do the monitoring, and then only I can monitor the fibroids growth.
Because basically the patients are very concerned कि हमारी जो गांठ है या रसोली है वो बड़ी हुई है
या छोटी हो रही है,
या कैंसर में चेंज तो नहीं हो रही है.
Right. Now just now you touched how to differentiate an adenomyotic patch from a fibroid. Very important point. Now see, I have to understand the pathology first of this adenomyosis. Then if I know the pathology, then I can differentiate. If I don't know, I cannot. Now, adenomyosis. Now when I say adenomyosis, what actually this adenomyosis is? This adenomyosis is an ectopic implanted, try to understand, ectopic implanted endometrium, am I right? Which is located where? In the myometrium.
Okay.
That is adenomyosis. But this adenomyotic patch is hormonally connected with the main endometrium.
Okay.
I am using word hormonally connected. Just for an example, which I am giving in each and every class, if I take this endometrium and put in my nose, and if I am a female, whenever I will be having bleeding PV, I will be having epistaxis also.
Of course.
Now, if it is of course, implement this of course over here. Now, if the patient is bleeding, I mean PV bleeding, during menses, menstrual bleeding is having a way out. Now, will this not bleed? You
Yes.
just told me, of course.
This
Will this not bleed?
will
This will also bleed, but this is not connected with the main endometrial cavity.
so it will be
It will get pulled up over here. Now see, try to understand. The blood will get pulled up over here. Here only, here only, here only, here only, here only, here. So now I am in day maybe first, for example. Day second, it is getting pulled over here. But this blood is having a way out. Patient is bleeding normally. But I am having a pooling over here. This will not drain out. Now, day third, day fourth, patient is over with periods. This endometrial has got shed out. But this has got pulled over here. I am at day 10th, day 12th, or day 14th. The pressure is increasing here. Try to understand. Pressure is increasing, pressure is increasing, pressure is increasing. And I am at 14 day, maybe 15th day. And pressure is increasing here to an extent that it is making a connection with the main endometrial cavity because of the pressure. And if it makes the connection with the main endometrial cavity, what will happen?
irregular spotting.
Now patient will have
Intermenstrual spotting.
intermenstrual bleeding. So this is the reason for this intermenstrual bleeding. Now come back. Now when I am at day 1, for example, I am at day 1, echogenicity of this endometrial patch will be like this. When I say like this, a hyperechoic one, a hyperechoic one. Let's take it this much hyperechoic. I am marking this like an echogenicity at day 1. Blood is getting pulled here, pulled here, pulled here. What will happen to this echogenicity? Will it drop or increase? Blood is having less of echogenicity.
So it will decrease.
It will decrease. Now see, I'm trying to understand.
Because
Previously
it's
it was
pulled
this
back.
much.
Because
Now it is this much. Now the blood has got shed out, drained out, I will say, when the pressure is increasing. After releasing the blood from here, what will happen to the echogenicity of this patch over here? Will that decrease or increase?
increase.
Increase. Now sometimes this echogenicity is over here. I mean more of echogenic. Sometimes it is less. It is not after 2 months.
Same.
It is
cycle.
just in same cycle, just after some days.
Okay.
That there is a variable echogenicity. Now keep this in your mind. Now when blood is pooling over here, what will be the overall size of the adenomyotic patch?
It will increase.
It will increase. When the blood will
It will shrink.
shut down, what the size will be?
It will decrease.
So it means that like echogenicity, this will also vary.
Yes.
That is what I told you, that if you are having a fibroid like, what you are thinking to be a fibroid over here, and if that fibroid is 40 millimeters when you are scanning, 40 millimeters when you are scanning, and previously, maybe in previous cycles, or maybe some 5 days before you or somebody else have scanned, was 20 millimeters only. Is this a fibroid?
No, this is not a fibroid.
Now you know. Why you know now? Now why you are saying with confidence, no, this cannot be. Because you are now knowing the theory. Now the echogenicity Previously it was very high. All of a sudden you are seeing a drop in the echogenicity. You are thinking that there are some red degenerations, white degenerations overnight. That cannot happen.
See, actually, this is not a theory, this is a concept which is once given, it gets inbuilt in our mind. So, this was like eye opener, and now I can say I know some fibroid and adenomyosis, how to differentiate.
So now I am leaving up to you this question. Now, see, the point here is that you have realized this thing that I am not directly answering the questions.
Yes.
If I will answer the question, that will be, in Hindi, the ratawan. People will copy that answer over here. Now a detailed discussion has to be there. For that, we are taking these types of, interactive sessions at regular intervals, but repeating this is not our course over there. Now, differential diagnosis of the adenomyosis from a fibroid. Now you can make out what varies.
See, differentiating fibroids from adenomyosis, first point is echogenicity. So, echogenicity of fibroid will be same throughout, and it will be equal to myometrium mostly, and this echogenicity will increase, decrease according to the menstrual cycle, variation in menstrual cycle, because this is ectopic endometrium in the myometrium. And the next point is about the size. Size will be it will be mostly same for fibroid, and it will vary according to the menstrual cycle and pooling of blood. Firstly, it will be some size, some standard size, and then it will increase in size, and then it may decrease also. And the next point is calcification. Calcification is mostly fibroid will be having peripheral calcification or so, and adenomyosis will not be having so much of calcification. And fourth point is about the peripheral vessels, color Doppler. Color Doppler, there will be more peripheral vessels in fibroid rather than in adenomyosis. So now I have a definite concept about how to differentiate fibroid from adenomyosis. Thank you.
Now, Dr. Gunjan, tell me honestly, you had this question in your mind. That is why I pasted it over here and make a PPT. Did I answer you like this? No, I didn't answer you like this. I cleared your funda. And if you know the pathology, you can decode the ultrasound language. But if you don't know the theory, you will never be able to decode the monitor of 1 or a 1.5
And one most important point I want to add is, if you want to monitor the adenomyotic patch in the same cycle, you can do the scans, and rather than sending it again and again to the radiologist, and patients also get disturbed if you send the patient again and again to radiologist. So you can do it, and it will be more interesting also.
Now, next point, what you had, this is your PPT, not your PPT, your question which I pasted over here. Endometrial CA, ultrasound findings. Now, ultrasound is all about how much you are thinking. The findings will be generated from here, from your mind, not from your eyes and not from your hand. More you think, good ultrasound you can do. Otherwise, you will be struggling.
As you say, more I stress my mind.
Right. Now, endometrial CA. Now, endometrial CA. If I am having a polyp, try to understand. If I am having a polyp, let me draw this like this. First of all, I may have a lesion which is over here. Why it is inside the endometrial cavity or touching the endometrial cavity. Can this not be a fibroid? Can this not be a fibroid? First, I am seeing a mass over there, a lesion over there. This can be a fibroid. Number second, adenomyosis. Can I not have an adenomyotic patch near this area? And I am unnecessarily thinking all lines of endometrial CA. Try to understand first. Adenomyotic lesion can be there. Can there be not a polyp? Now I have to be very clear with the polyp, this polyp first, fibroid first, and adenomyosis also. Now comes to the endometrial CA. In this endometrial CA, what I have to see first of all is the age. Right? Now you tell me how much of endometrium you will expect with the age.
Depending on the phase of the cycle.
Not phase of the cycle, no.
Okay.
Postmenopausal, premenopausal, how much is the cut?
Sir, premenopausal it will be 4 to 5 mm.
So 5 millimeters. Now you are having not 5 millimeters but at 12 millimeters, and you will see the age also. Now you will think of endometrial CA, but before jumping on to the endometrial CA, can there not be a polyp like this? Polyps are not always looking like polyps what you are thinking like. If I am having a long polyp with a long pedicle, it will go into the endometrium, whole of the endometrium, and you will think that I am having a thick endometrium. Now if you think that I am having a thick endometrium, all of a sudden you recall, not all of a sudden, you know that I will not expect more of endometrium, 5 millimeters, and this endometrium will be more than unnecessary. You will be thinking of labeling a polyp. That is why I wrote it over here. Unnecessary, you will be labeling or thinking on lines of a polyp. But let's discuss this polyp and differentiate it with the CA. If you put a color Doppler, this is the polyp over here, and this is the endometrium over here. On putting a color,
Feeding vessel.
will there be, forget about feeding vessel, will there be central flow in this polyp?
No.
So I will not see more of the central vessels. And if I see more of the central vessels, then I am not dealing with a polyp. Not dealing with a polyp. Point number one. Point number second is this age first. What will hit my mind, what will knock my door, what I say is this age first. Okay. Now if I insert a saline, this polyp will pop up. So the clarity of this polyp will increase by tens of folds if it is a polyp.
Yes.
But try to understand, will this endometrial CA picture increase 10 by tens of folds if it is a CA? No.
Of course.
So the basic important point is that you have to keep multiple things in your mind when you are about to diagnose a endometrial CA, because if you label a non-malignant case, a benign case for a malignancy, imagine how much pressure the patient will have, and patient will never forgive you when she will rescan. She will never come to your clinic, oh, his doctor ne to mere ko cancer paste kara tha. But on in the same breath, if you miss a CA and you label it for a benign, and it turned to be a malignant case, then not patient, you will not forgive whole of your life that I have missed this case. So the point is that, now see again, how much theory is needed, then only you can decode the ultrasound monitor.
Basic clarity.
So next point is different ovarian cysts. Now let's keep this thing for some other day, because this will take about 40 or 50 minutes only, because here in ovarian cysts I have to see whether I am dealing with a simple ovarian cyst, then I have to see differentiate it. So this can be a simple
functional,
right. So then it can be a dermoid also. There can be a dermoid. There can be an adenomyotic cyst. Adenomyotic cyst, para-ovarian cyst, and complex cysts. Now these complexes can be malignant. So this is itself a big topic over here, which we will keep for next time. And today we will take this question. This is not a question actually, this is the point. How to measure an ovarian volume? Okay, so first measure the ovary, then only you can make out whether you are dealing with a PCODs or a normal ovary. So the basic important point is how to measure the ovarian volume. Dr. Gunjan, tell me honestly, have you not seen a case which was labeled for a PCOS, but when you investigated it thoroughly, the PCOD is tiny? And have you not seen a case which you are thinking, the report, which you are thinking will be labeled in red as PCODs and it came to be normal?
Yes, of course, so many times.
So what happened? What went wrong?
Actually, overdiagnosis of PCOS due to wrong measurements.
Wrong measurements, right. Now when anybody means anybody, whosoever is doing ultrasound, is not knowing how to measure an ovary to get a volume, he will get a more or a less of volume, and then your diagnosis will change. Not your, his diagnosis will change. Now, machine is born blind. Machine neither has the brain nor eyes. Machine is not thinking. Machine is obeying your commands. Whenever you are pressing onto a volume button, machine is asking for three measurements. Now these three measurements has to be given by you to machine. Machine is born blind. Machine cannot say you, no doctor, you are taking it wrong. Take it like this. No. Machine is asking for three measurements. You press on your volume button, a cursor will appear. You will take this. This can be length, width, but machine does not have eyes. Machine is taking it for granted that you have taken one, and that one you know what you have taken, maybe a length. What is next? Length, breadth and depth. So this length, this is the breadth, width I will say, right? And this is the depth. Width, depth and length. You have to give these measurements to machine, which the machine is waiting for, but machine is born blind. Now, if you give a wrong width to machine, when actually that was 5, for example, you gave 3 to machine, what will be the total volume? It will be less. So your PCODs, ovaries will look like a normal ovary, but if actually that was 5, you are taking it wrongly. I will elaborate what the wrong and right is. But first understand the concept. If it was 5, but you gave it 10, now your normal ovary will be labeled by your high-end machine as a PCOS. Now, come back. This length, width and breadth. Length is, in Hindi we call it lambai. Lambai can be taken in longitudinal or in transverse section. Longitudinal only, right? Longitudinal only. I can take the length in longitudinal only. I am stressing on only. Now, in your machine, there is a dual mode. Dual mode is not to save the paper, but keeping your ovary over here, one and second one. Picture of the same ovary. Now, over here, I put a longitudinal. Now, how to take a longitudinal? For that, you have to complete the course. Okay. Now, here, this is the longitudinal section. This is the LS. Longitudinal section. and this is the transverse section. In longitudinal section only I can take the length. Now this is the length. You have to take it from superior to inferior.
So it depends on the positioning of the probe.
Right.
And how you locate the ovary and how you have to rotate the probe.
Right. For that you have to clear the screen orientation as well.
Screen orientation, location of ovary, and we have to say the sections through different movements of the probe.
Right. So this is the length. So length can be taken in longitudinal section only. Now come in transverse section. In transverse section, when I measure from this point to this point, you tell me what actually I am measuring. Recall the volume. There are three measurements which measure depth. So this is depth, D for depth. And when I am measuring from right to left, what I am measuring?
Width.
Width. Now, if you give this depth means this way you have to measure, and width this way. So this is in transverse section. Can I take length in transverse section?
No.
Now, if somebody takes one section only, a transverse section, for example, a transverse section, and taking length this way, what will be the ovary given by machine, ovarian volume I mean, will it be more or the less?
It will be very less.
It will be less. So here, if my ovary is 9 cc, for example, let's keep this 9 cc, will I get it 9 cc less or more? Less. So it can be a 6 cc. Now I am labeling. I am not labeling. Machine is giving me 6 cc. I am cursing machine. Actually, I don't have to curse the machine. I have to see over here what I am measuring. I am measuring length this way. And if I give length this way only, then only I can get it 9. Now, second scenario. Second is, if I take this section only I am using word. I am taking length like this, and then I am measuring width like this and depth like this, and my original ovary is 9 cc. What this will look like? Not look like. What the machine will give me?
More measurements.
20 cc.
Increased
volume, not 9. Now you will label this ovary for PCODs. And you are doing this thing not onto right side but onto the other side also. Oh, 20 cc. There are many follicles. This is a PCODs.
Okay.
So the basic important point is that know your screen orientation. Know that I have to keep longitudinal section here and the transverse section here, and this dual image is not to save your paper but to take the volumes only. This volume can be ovarian volume or any volume. So machine is born blind. You have to put your brain in the machine, then only machine will work. So these all things I think that
actually you mean to say, if this is a person and we take a transverse section is like this, and if we are measuring the length in a transverse section, we'll be not measuring this length, we'll be measuring only this length.
Right. Now see, these things are from screen orientation. That is what I told you. You have to clear first the screen orientation. So the basic important point is that not basic important, the moral of the discussion of this ovarian volume is that you have to keep ovary onto the both sides of the dual image. One, you have to keep longitudinal, one in transverse, and in longitudinal only I can take the length, and in transverse I can take the depth and the width. Then only whatever volume the machine will come with is the actual volume of the ovary. Anything else?
Thank you so much. That was an incredible presentation, which I could expect only from Dr. Wani. So that was an eye-opener. Thank you so much. Thank you, sir.
Okay. God bless all of you. Thank you.